Professor Contreras, the next issue I'm going to ask you about is that of record keeping. I'm going to ask you first to look quickly with me at two documents which we looked at earlier in the week with Dr. Napier, but for the benefit of those who may not be familiar with them. The first is RLIT 40215. This is a 1952 report of the World Health Organization's Expert Committee on Hepatitis. Shomik, if we can go to page 20, please. This is one of a number of preventive measures which the committee recommended in relation to a response to transfusion-transmitted hepatitis. Maintenance of records. Subsidiary but important means of control are afforded by the maintenance of accurate records of the origin, distribution and administration of blood and blood products. Such records should include 1. Record of the names, etc. of donors contributing to each product, 2. Recording of batch numbers of products issued to hospitals and systematic distribution of products to hospitals. Now, just pausing there, 1 and 2 would be the responsibility of the transfusion centre to maintain. Yes. And then 3, this would be the responsibility of the hospital, presumably where treatment was administered.
Yes.
So accurate recording in the patient's case papers of the batch number of the product used, date of administration, and of the patient's name in the hospital record of products received and issued. So would you agree those are basic principles but of fundamental importance?
Yes.
And then we can see how that was, in particular in relation to category 3 of records, was emphasised in a 1973 document, Notes on Transfusion, HCDO 40861. So we can see the title of the document there. This is the revised 1973 version. And if we go to page 3, and obviously this predates your appointment as Regional Transfusion Director, but we can see this edition of Notes on Transfusion, like the 4 previous editions, has been prepared by the Committee of Regional Transfusion Directors of the Department of Health and Social Security and Welsh Office. So your predecessors as Regional Transfusion Directors would have contributed to this, and it's presumably a document you were familiar with.
I'm sure I'm not.
And then if we go just to page 18, we've got the heading Transfusion Records. A record of every transfusion should be made in the patient's case notes, in addition to the details recorded in the transfusion laboratory. It's not always appreciated that the main reason for accurate recording is the protection of the patient. And then I won't go through the details, but there is then set out what should be recorded in the patient records on the top half of the page, and then towards the bottom of the page it sets out what should be recorded in the laboratory records. And that continues if we just go to the next page. Continues over the page. So it would be right to understand that these were the standards in terms of record keeping that hospitals using blood or blood products were expected to maintain.
Yes.
Now, I'm going to ask you to help us understand the record keeping in relation, first of all, to categories 1 and 2 from the World Health Organization. So record keeping in relation to donors, and then record keeping from the centre in relation to the products that were sent out to hospitals. In terms of donors, if we go to your witness statement, so if we could have back Shomik WYTN 5711001. And we go to page 43. You describe here the system at the North London Transfusion Centre in terms of records of donors, something called 101 cards, is that right?
Yes.
And you tell us in paragraph 162 towards the bottom of the page that this method of record keeping was in place when you became director. Sorry, it's paragraph 162, Shomik. And you didn't make any changes to the system. And then if we just go back and look at paragraphs 160 and 161, the 101 card would have details of the donor, name, address, date of birth, donor history, and they'd have different colours for various reasons. And then there'd be donor session details, which you describe in paragraph 161 as well, and there would be bleed sheets specific to each donor session. So would it be right to understand that you would have, for every session, you would have a list of who had donated? Is that right, on the bleed sheets?
Yes.
And then for every donor, you'd have the 101 cards, which set out their own personal history of donation.
And for the new donors, we had a buff card, 101 card, a new 101 card, until they were grouped, and then they went to different colours.
So that, I think, helps us understand how records were kept in relation to donors. Could you then just explain for us what the record keeping was in relation to what then happened to the donation? So the unit of whole blood or red cell concentrate or whatever else it was that was processed at the centre, what records were associated with the production of that unit?
Every donation had a number attributed to it, and as I explained in one of the documents, we gave labels, additional labels with that unique donation number, and then later on we had a donation number and a donor number as well, and that, so if a unit, a pack of blood, was split into fresh frozen plasma and platelets at the blood center, the number of the donation would be on the additional packs, because that pack was not separated until it was labeled, so you separated plasma or cryoprecipitate and platelets from the unit, and they all had the same unique donation number.
So at the point in time at which a blood product component left the centre to go to a hospital, you would know, or you would be capable of ascertaining from whom the original donation or donations came.
Yes, yeah, we could trace back to the donor.
What then of the position in relation to the records that the hospital was supposed to maintain in relation both to entries in the patient records and then entries in the hospital's laboratory or blood bank records? Did you ever have access to that data?
No, I did, unless we were following up a unit, or we followed up a report from a hospital of a transfusion-transmitted infection or an error or anything like that, then we would have access to the records, but not routinely. But what we did is we had meetings with the medical laboratory scientific officers in charge of blood banks, and there was always a consultant hematologist in charge of a blood bank, and we had meetings to remind them of the importance of record keeping. Yeah, but we didn't, and we also issued an issue note for every hospital with the numbers of all the units given to them, and they had to sign. It was an original and a copy, and I think they kept the original and sent the copy back to us, signed that they had received all those units.
And then if we can just look at a handful of documents about record keeping. If we start at DHSC 0101588, please, Shomek. This is a letter 9th of March 1982 from you. Oh, no, sorry, if we go over the page, it's from Dr. Davis, your predecessor. Just look at the next page. So it's from your predecessor to Dr. Wolford. and if we go back, go back now to page 1. Heading record keeping in the NBTS and hospital blood banks, and it refers to a letter to Dr. Wagstaff, and there was a degree of investigation or inquiry ongoing in the Department of Health at this time about record keeping. And then Dr. Davis says in the second paragraph, second line, anyone investigating our records, so the centre's records, would have seen that all issues of blood and blood components are fully recorded, and hospital staff sign issue slips on receipt of the blood. So was that the system that was in operation when you took over as director?
Yes.
And that continued to be the system?
Yes.
And in due course it became computerised, but that was the basic system. And then Dr. Davis goes on to talk about then the hospital records. He says, third paragraph, fourth line, at Edgware, as I'm sure at every other transfusion centre, we have accurate records of issues to hospitals and of returns from hospitals, but we have no records of the final disposal, i.e. the recipients. If it is assumed that 3 units are used per transfusion, then last year approximately 53,000 patients received blood issued by Edgware. I foresee problems in persuading the many hospitals we supply to forward regular and accurate records of recipients for the RTC to match up with recorded issues to the hospitals. I consider that once the hospital staff have accepted the blood, it is their responsibility to keep records of the final disposal. And was that your view as well?
Yes.
And did that remain the position while you were director? The hospital was expected to maintain its own records?
Yes. But it was much easier in my days because they had computerized systems, and so they could, like in a supermarket, they could run the reader through the coder bars.
Now, it does seem as though there were problems about the extent to which hospitals that you supplied were maintaining accurate records. And I want to look at a couple of letters from 1988 in that regard. If we start with NHBT 0115386, please. So this is a letter from you to Dr. Seymour at the North West Thames Regional Health Authority, 3rd of May 1988. And it says this: you asked me to send you a draft for a letter to district general managers regarding record keeping of units of blood transfused in hospital. I proposed something along these lines. And then this was your draft. The director of North London Blood Transfusion Centre, so that's you, has informed me that some clinicians, especially those in theatres and intensive care units, are not complying with the DHSS circular on record keeping and stock control arrangements. The circular states clearly that records must permit the tracing of any unit of blood from collection to transfusion or disposal. Dr. Contreras has informed me that when trying to investigate the ultimate fate of blood or blood components involved in suspected cases of transfusion-transmitted HIV or HBV infection, it has been impossible in some cases for her or her staff to know with certainty whether a specific unit of blood was actually given to a particular patient, since no entry was made in the patient's notes. On all occasions, the records in the blood bank were adequate, but the fact that blood or blood derivatives were issued for a named patient does not necessarily mean that they were actually given to the specific patient. And then there's a reference to the new product liability regime. The letter, in some respects, speaks for itself. Is it right to understand from this that this issue about record keeping came to your attention because you'd been trying to trace what happened where you had the possibility of a donor who may have transmitted HIV or HBV?
It was before then, you know. I always knew that a unit of blood given or the components given by a donor we should always know the ultimate, or somebody should know the ultimate fate of that unit transfused. And it was, I think it was before that letter when some units of plasma started disappearing as well, that it emphasized the need for adequate record keeping.
And was it your experience that it was quite common to find that hospitals were not adequately discharging their record-keeping responsibilities?
Yes, it was quite common.
This letter suggests that at this point in time, the problem was predominantly in terms of the patient records as opposed to the laboratory or blood bank records.
Yeah, the blood bank records were always quite good, very good. And, when they were issuing units, as I said, it was particularly in theatre or ITU that units were not properly recorded.
And then we can see there's a further letter in 1988 that you wrote, NHBT 0085222. September 1988. This particular letter is to a consultant haematologist at Queen Charlotte's Hospital, and the first paragraph refers to you having made a visit to the blood transfusion department at the hospital. And then you say the purpose of this letter is to remind clinicians of the DHSS circular on record keeping and stock control, which I enclose. And then, skipping over a few lines, you say, we must ensure that the ultimate fate of a unit of blood, a blood component or a blood product is known beyond any doubt. I note that the system of record keeping in your blood transfusion laboratory is very good. However, I am not quite sure whether clinicians are fully aware that they are responsible for ensuring that the donation numbers of the units transfused are entered in the patient's notes. I know that you supply self-adhesive forms with the donation numbers of the units cross-matched by your laboratory. However, clinicians must ensure that such forms are stuck on the patient's notes. And in addition, the person giving each unit of blood should enter the number, date and time of administration with a legible signature that will facilitate any further investigations in case of adverse reactions to transfusions. Accurate record keeping is vital, and traceability of every unit of blood must always be maintained. And then you go on to deal with another problem in the next paragraph. An essential part of record keeping involves adequately completed transfusion request forms, as well as properly labelled tubes containing blood samples. I've noted that a large number of transfusion request forms at Queen Charlotte's are not completed in a satisfactory way. Information is often lacking regarding previous pregnancies, transfusions, diagnosis, etc. What was the transfusion request form, and why was it important to have that completed comprehensively?
The transfusion request form is the request form from the clinician, from the consultant treating the patient. Usually it was filled in by a junior doctor or a senior registrar or registrar. And it was the request form with the name of the patient, the date of birth of the patient, the hospital number of the patient. It needed to have all those, the diagnosis and the hemoglobin if red cells were needed, or the platelet count if platelets were needed, and the reason for the transfusion. Every hospital had their own transfusion request forms.
And would it be right to understand that one of the reasons why it was important to have such documents completed accurately is the reason you've given here, the need to be able to trace every unit of blood. But would it also be right to understand that recording the reason for transfusion would be important in terms of wider issues about transfusion practice to ensure that transfusions were only being given when they needed to be given?
Yes.
We can take that down, thank you.
Can I just ask, the theft that took place of plasma, was that about this time, late 80s?
Yes, it was before. Yes, sir. It was before when I was deputy director. It was between 1980 and 1984, and yes, it occurred around that time.
And the plasma which was sent to the hospital from where it was taken, that would have been recorded in the way you've just described.
It should have been recorded.
So if the hospital had been keeping proper records, they should have known where each unit of plasma had gone.
Yes. And that was what, in effect, that was when the department became worried about transfusion records, because the ultimate fate of many units of fresh frozen plasma could not be known.
And it must follow that because no one presumably noticed for a while, and because presumably the consultant thought they could get away with it, taking the plasma, that is some indication of the poor state of record keeping by the hospital at the time.
Yes, sir.
Yes, I see. Thank you.
And Professor Contreras gives, I think, an outline of her own involvement in relation to observing the then Chief Medical Laboratory Scientific Officer at the Edgware Centre in her statement at paragraph 44, for those who are interested in reading it. If we put your statement back on again, WITN 57110001, and we go to, sorry, forgive me, page 51. I'm going to come back to the issue about jaundice inquiry reports that you deal with in paragraph 202. Paragraph 203, you talk about the situation of a donor who was found to have been excluded by another regional transfusion centre. And I think you explain in paragraph 204 that there was no scheme prior to the National Information Technology System which enabled proper data sharing between different regional transfusion centres, which were, as you've described, these independent autonomous centres. Is it right to understand there was no system for enabling Centre A to tell Centre B the details of the donors they'd had excluded?
Yeah, there was no system.
And no way Centre B could contact Centre A and say, we've got a donor here, have you got any records of that donor? Was that possible?
Yes, if the donor told us that they'd been a donor at another centre, then we would immediately contact the other centre and say, could you please tell us whether this donor is fit and send us the 101 card for that donor.
And if we go over the page, please, Shomek. You, I think, essentially make that observation in paragraph 208. There was no mechanism for a centralised database shared with other RTCs about excluded donors. It was only when donors told us they'd moved. But otherwise, we didn't really share information until the national IT system was created. And then the bottom of the page, 210, paragraph 210, with respect as to whether I believe the measures in place between RTCs were adequate in preventing donors who were suspected of carrying blood-borne infections from continuing to give blood, I have to say that I do not think the systems were adequate because we did not really have a system that would have prevented the risk of an infectious donor donating somewhere else. All we could do was to advise donors known or suspected of carrying blood-borne infections that they should not continue donating, giving them the reasons for this advice. And then you say in paragraph 211 that the donations by donors known to be carrying blood-borne infections would only have taken place where a donor was maliciously doing something, and you never encountered such an event. But it might be the case, might it not, Professor Contreras, that you could have a donor who hasn't actually been adequately counselled or given proper information, doesn't understand that why they've been excluded from another centre, who may perfectly innocently, non-maliciously present themselves to a further centre. So that could happen.
Oh, yes, that could happen. But I must say that with the papers I was sent, I was reminded of a donor that we had at our centre.
I'm going to ask you to look at the... Yeah. So that is NHBT 5030_007. I'm hoping we're thinking about the same thing. It's an article in by Dr. Barbara, you and Dr. Briggs. Is this the case you were thinking of?
I think it might be. It's a donor who came twice to give and he was positive. Yeah.
Yes, exactly. So we can see it set out in the first paragraph In the absence of specific tests for non-A, non-B hepatitis viruses, evidence for their involvement in post-transfusion hepatitis can only be circumstantial. This report describes an example where 2 successive blood donations, spaced by 7 months from the same donor, were both implicated in cases of post-transfusion hepatitis. And then you describe a donation given as whole blood to a patient who became jaundiced 6 weeks after transfusion. And then if we go to the top of the next column, talks about how the donor was asked to refrain from blood donation until further notice. His records were withdrawn from our routine donor file. Despite these recommendations, he returned as a new donor 7 months later, and his donation was one of 4 units given as whole blood to a patient. So is that the occasion that you were thinking of?
Yes.
And can you help us in understanding how that occurred?
Well, you know, as I said, the first donation went into a patient who was one of the 2 units given to that patient, and the hospital, I think weeks or months after the transfusion, reported that the patient had hepatitis, elevated transaminases, I think. And so we went back to those donations and to those donors and found that they had, I think, abnormal ALTs or something. And we told those 2 donors not to please not continue donating because we thought that they had an infectious agent. So we withdrew that 101 from, or we marked that 101 as non-suitable donor. And we counseled him personally. We never referred donors to the GP, but Dr. Hewitt was responsible to follow up those donors and counsel them, and she had a team of doctors to do this. So the donor was adequately counseled to please not come and donate again. And we do not know why he came to donate again as a new donor. And that then, as soon as we knew that it had been that donor, and it was unfortunately after his unit had been transfused, that we realized that the red cells had gone into a patient, so we informed the hospital concerned, the consultant concerned, and they followed up the patient and realized that that donor had transmitted non-A, non-B hepatitis.
And leaving aside whatever the motivation of the donor was in coming back, having been counselled not to, coming back to donate, how was it that the centre's records didn't identify this as a person who had only months previously been advised not to donate?
Because if a donor comes as a new donor and doesn't tell us, and we had all this collection of 101 cards, so there could be, 100 John Smiths in our panel. So we couldn't go through all our record system to identify that person as a previous donor until we were computerized.
You anticipated my next question. So a computerized system would be likely to pick that up?
Oh, yes.
But it wouldn't be picked up on a manual system if the donor told you they were a new donor?
Yes.
Presumably if the donor said, I've been here before, even if they didn't give details about what they'd been told on the last occasion, would you then have, rather than giving them the buff-coloured new 101, would there then have been, before that donor donated or before their donation was used, a check on their old records?
Oh, yes, we would inform the centre. We would give him or her a buff 101 card because we didn't have the records there. But if I've donated a unit before, then we would immediately say, this is not a new donor, please check that there are records for this donor.
And would you expect that check ordinarily to be done if the system was working properly before any of the donation was used?
Before any component was made.
Okay. And then just on the issue of being able to check records of donors from other centres, if we look at JPAC 5035_159, please. The issue under discussion here, as we can see from the heading, is readmittance of blood donors who've tested repeatedly positive but are not confirmed HIV antibody positive. This is an undated document, but we can see that it must be at some point after May 1987 because it refers to a meeting of the Expert Advisory Group on AIDS in May 1987. Just wanted to draw your attention to paragraphs 3 to 5. Dr. Contreras drew attention of members to the organisational difficulties of the recommendation requiring that the records of donors who transfer to give blood at a new centre be checked to ensure that previous donations had not been found antibody positive. Eager members agreed that this recommendation should be considered further by the Regional Transfusion Directors Committee. At the meeting of the Regional Transfusion Directors in July, it was universally agreed that it would not be practical or even possible at some centres to check previous records of donors in this way. And that essentially remained the situation and remained a problem until there was a national database, effectively, a national IT system sometime after 1995.
Yes.
If we then just go back to RLIT 40215, please. This is the World Health Organization report. If we go to page 21. Sorry, if we go to page 20, my apologies. So we looked at the section on maintenance of records, and then we have a section on reporting. Second sentence, the committee feels that useful additional information might be obtained by a simple follow-up system to detect cases of serum hepatitis following administration of blood and blood products, and then some further suggestions are made. So it's fair to say that the importance of reporting cases of post-transfusion hepatitis have been recognised for decades.
Yes.
Now, in terms of the systems in place within England and Wales, I just want to look at a couple of documents that predate your time, just to see whether the system described was the system in operation when you took over. So if we start with NHBT 0016498, please. You'll see, Professor Contreras, this is a Regional Transfusion Directors meeting in November 1973, so some years before you took up your post as Deputy Director. If we go to page 7, I should have said Dr. Davis, your predecessor, was at this meeting. Page 7, second paragraph, describes Dr. Maycock outlining the present voluntary system used by RTCs to gather information about reactions and report them. And then he records that 1, cases of serum hepatitis were reported to Dr. Maycock on a special form. This system had been in use since 1946. And then he goes on to then deal with transfusion reactions and certain other reactions, such as allergic reactions. And then if we look further down towards the bottom of the page, it was recommended in notes on transfusion that serum hepatitis, reactions to infected blood and all severe reactions should be reported at once to RTDs. The reason for this was because appropriate action... Oh, system's gone down. Thank you. At the bottom of the page, appropriate action must be taken by the RTC without delay regarding donors or procedures within the centre. And then if we... sorry, I'll carry on. It was important for the same reasons that reactions associated with plasma or plasma fractions should be reported without delay to BPL. And then if we go over the page, second sentence says the numbers of cases of serum hepatitis and other reactions reported varied widely between regions. The method of reporting was then discussed. Several directors thought that reports to CSM, presumably Committee on the Safety of Medicine, should be made by hospitals, since the details of the yellow report card issued by CSM could only be completed in hospitals. After discussion, it was agreed that if reports of adverse reactions concerning blood and blood products were to be made to CSM, such reports were best made by RTDs, because they almost always heard of and investigated serious reactions associated with blood and blood products. It was not essential that the yellow card was used, providing the name of the doctor in charge of the patient was reported. After further discussion, it was agreed, A, that cases of serum hepatitis should continue to be reported to Dr. Maycock on the usual form, to which a space for the name of the doctor in charge of the patient would be added, that any other serious reactions, e.g. to infected blood, would be reported to Dr. Maycock using the form notification of transfusion reaction. And then if we skip down a tiny bit, it says it was further agreed that this subject should be reviewed early next year. Now, that's obviously 1973. Come 1980, when you take up your post as Deputy Director, was there still a system in place for reporting, for the Regional Transfusion Centre to report cases of serum hepatitis, post-transfusion hepatitis? And if so, to whom?
There was, as far as I can remember, there was a system from North London Transfusion Centre. Dr. Barbara collated all those cases and made a report, an annual report that was sent to the CDSC at the Public Health Laboratory Service. I think it was Dr. Sheila Polakov who collated all. It was like mandatory. I don't know whether it was mandatory, but we sent all this. The reporting was centralized at CDSC.
Okay. So, obviously, the reports to the Regional Transfusion Centre and then reports by the Regional Transfusion Centre. Would it be right to expect that hospitals should report cases of hepatitis that might have been associated with the use of blood or blood product? You would expect hospitals to be reporting that to you?
Yes.
To what extent was that reliably done? Maybe impossible for you to answer because you only know what's reported to you, but...
I think that in my time, because often the hematologists in charge of the blood bank would not know, but if the hematologist in charge of the blood bank knew, or anybody knew that there might be an association between the hepatitis or any transfusion event and the transfusion of a blood component, they would report it to us.
So there's reports to you, and then your recollection is by the time you're there, the report is made by the centre, you think, on an annual basis to CDSC?
Yeah, well, once the report was made, once we were notified of a case of possible or probable transfusion-transmitted infection, then we would go to the hospital, we would contact the hospital and investigate whether this was a real case of post-transfusion infection. And if it was a real case of post-transfusion infection, we would then go to the serum archive and investigate the units given to that patient and, if necessary, call up the donors involved.
Do you recall there being still in operation a yellow card scheme, to use the phrase? You don't. If we then look at your statement, so if we have the witness statement back, please, Shomik, WITN 5711001, and go to page 51. We can pick up at paragraph 202. I think the system you were describing operated by Dr. Barber and his team. You say in the third line of paragraph 202, Dr. Barber's team always prepared JE, jaundice inquiry files, for any reports of post-transfusion jaundice, or indeed of lab test positive results for viral hepatitis in patients following blood transfusion. That's the system in operation at North London. Other than, you think, reporting that on an annual basis to CDSC, was anything else done by way of reporting by the centre of such cases? To the Department of Health or anywhere else?
No, because the CDSC was acting, I think, on behalf of the Department of Health. So, this report went to Dr. Polakov and to region when we were regional. And do you to our regional medical officer?
And do you have any recollection of roughly how many jaundice inquiry reports Dr. Barbara's team might gather in a year?
Not really. I remember that, the real cases of post-transfusion hepatitis were about for a year or something like
that. If we assume a case has been reported to you, and so Dr. Barbara is going to be, or his team are going to be completing the jaundice inquiry report, what are the steps that the centre would then be taking to investigate that?
Well, we would be immediately in touch. The doctor concerned with that hospital and Dr. Barbara would be immediately in touch with the hospital and see if we could, we would have access to the records. We would go to the hospital and have access to the records and investigate, because often the cases that were attributed to blood transfusion, the donor had markers of a very long-standing hepatitis that was not attributable to transfusion. So the steps were investigate where it was a real case of post-transfusion hepatitis, and then get samples from the patient and investigate the archive samples, because we always kept serum samples from all the donations that we collected. And so Dr. Barbara's laboratory would go back to those archive samples and investigate them. And anybody found positive or doubtful positive, the donor would be contacted and we would sample that donor again. And if found positive, we would, Dr. Hewitt's team would advise them not to continue donating, and so complete the jaundice inquiry.
And having done all that, would you then, or the centre then, be taking the next step of seeking to trace the recipients, other recipients, so not the one reported by the hospital in the hospital report, but other recipients of donations over the years? Was that step also?
Yes.
So a form of look back, I suppose, but on a local basis, would you try to make contact?
Yeah, we would try to make contact, and sometimes we were successful, and sometimes we couldn't find the ultimate fate of those.
And so, just thinking it through as I ask you the question, you would presumably be dependent upon them, the reliability of hospital records, because you'd be able to see what had happened to a donation 3 years ago from donor X, because your records ought to be capable, as I understand it, of telling you that components made from that donation had gone to Charing Cross Hospital on such and such a date. Is that right?
Yes.
But you wouldn't know what use had been made by them of Charing Cross Hospital unless the hospital records had been completed. I mean, would that then be handed over to the hospital to follow up, and to try and make contact with the patients who'd been treated with the suspect donation 4 years ago? Or was that something the centre would be doing?
No, we had no authority to go back to the patient, so that if we knew, if it was known that a recipient had contracted, that had the possibility of having been infected, then we would pass that information on either to the hematologist, or the hematologist would pass it on to the relevant GP, or if there was a clinician in charge of that patient, to the clinician in charge of the patient.
And if we just go to page 77 of your statement. So you say in paragraph 306, as you've just told us, that whenever a case of post-transfusion hepatitis was reported to our blood centre from hospitals in our region, we conducted full investigations with further testing of the patient samples and of the implicated donors to identify a possible source of infection. And then you say this, at NLBTC, we tested for markers of hepatitis B, including anti-HBC and LFTs. Now, can I just be clear what you're saying there? You're not, as I read your statement, saying that you screened all donations for anti-HBC.
That's right.
You, this was an additional investigation that you undertook on implicated donations?
Yes.
And would you be calling the donor back in?
Yes.
Through Dr. Hewitt's team or whoever it might have been, and asking them to submit to further tests?
Yes.
So there wasn't routine across-the-board anti-HBC testing?
Sorry.
There wasn't routine across-the-board anti-HBC testing?
No. Only for our apheresis donors, but no, it wasn't across the board.
Did you ever get any impression as to whether hospitals were either slow or reluctant to report cases of post-transfusion hepatitis or possible post-transfusion hepatitis or jaundice to you?
No, that I can remember.
We can take the statement down. Actually, no, sorry, we'll keep the statement up and go to page 24. I'm going to ask you next about a different topic, so self-sufficiency, supply of plasma to BPL. If we start by looking, sorry, Shane, my fault, paragraph 88 rather than page 24. Page 24, yeah. So you said in paragraph 88 that you can't recall the exact plasma targets that were set before the year 1989 to 1990. We looked earlier at the targets that you had in relation to 1989, 1990 onwards. And your recollection as set out in your statement at 89 was that the targets must have been set by the Department of Health in conjunction with BPL. So these are not targets in terms of numbers of donations, which you set. This is the target of how much plasma you supplied to BPL.
Yes.
We know from other material that it was in 1981, I think, that the pro rata system was introduced, whereby an amount of plasma would be supplied by a regional transfusion centre to BPL, and then there'd be a pro rata delivery back of concentrate from BPL to the region. Do you have any recollection, because this is before obviously you took over, but do you have any recollection of how well the pro rata system worked and whether it secured sufficient Elstree factor VIII concentrate?
There was never sufficient factor VIII concentrate from Elstree.
Can we go to CBLA 000180, please? This is a report from Dr. Gunson to the Central Blood Laboratories Authority, CBLA, headed Plasma Supply for Self-Sufficiency. It's a report dated January 1984. If we look at the second paragraph, Dr. Gunson says this: during the latter part of 1983, informal comments from some RTDs gave cause for concern in that the targets which had been agreed as a planned programme were in jeopardy because of difficulties in obtaining the necessary funds. Accordingly, in December 1983, I wrote to each RTD asking for their personal assessment of the situation with respect to obtaining the necessary quantity of plasma by 1986, and their views on their region's attitude to the subsidising of other regions who could not attain self-sufficiency. Their replies are summarised in the appendix to this report. It will be noted that only 3 RTDs are confident that their RHA will support the programme for increasing the plasma supply. The remaining replies range between not hopeful of the necessary finance to an inability to predict the outcome of discussions with the RHA. 2 factors in the replies were of significance, and then the first was that many RHAs weren't willing to consider proposals on a more than a year-by-year basis. The second factor was about demand for PPF. So if we could just then turn to the next page, we've got the results of Dr. Gunson's survey set out centre by centre. And if we go to page 3, we've got North West Thames. Now, this is a survey that would have almost certainly, I think, have gone to Dr. Davies rather than you, because it's late 1983. But we can see what's set out there. Target 18,500 kg. Budget for 1984-5 has not yet been established, but expects finances to be made available to allow this target to be met. And then for 1985, increases in the 1984-5 levels could not be made without additional space, and this has been agreed by Regional Medical Officer and RHA Development Department to be a priority. However, although RHA are aware of expansion in plasma supply, no official discussions have taken place and no finance allocated. Just pausing there, you then took over as director in February 84. Can you recall the substance of any conversations you held with your regional medical officer about having sufficient funding to be able to provide enough plasma to BPL to meet your targets?
I remember having conversations with my regional medical officer and the regional treasurer about funding in general, because not only did we have to supply plasma to BPL, but we had a large demand for fresh frozen plasma and platelets from hospitals. So there was a general problem of funding. Yeah, that's what I remember. And I was passionate about self-sufficiency, so I must have made a case also for plasma for BPL. But we had the problem of, of supplying enough plasma for the hospitals, teaching hospitals and demanding hospitals, and supplying plasma to BPL.
And I think we probably see that point in the third comment on the right-hand side. This is in a column headed confidence of RTD in ultimately achieving target. Every effort will be made to achieve targets, but demands from teaching and specialised hospitals reduce availability of plasma, and doubtful whether the region could become self-sufficient for factor VIII. In any event, I think it's right to understand from one of your earlier answers that that there was not at this point in time enough BPL factor VIII to meet all the needs of the haemophilia centres in the region that you supplied.
Yes.
Now, in terms of plasmapheresis as a means of increasing the amount of plasma that might be available to provide, if we look at NHBT 00164998, please. This is a set of minutes we've already looked at. for a different purpose in November 1973, so again before your time. If we go now to page 4, the context of the discussion is something called Wedgwood plates, which were, I think, something given to donors who gave lots of donations.
100 donations.
But if we just look at the bottom of the page, we can pick up a discussion about plasmapheresis. It says, Dr. Maycock suggested that although Edgware was the only centre at present at which many donors gave 100 or more donations by plasmapheresis, new regions would eventually become involved in these awards. So it would appear from this that by 1973, at the North London Centre, plasmapheresis was already a well-established part of the system. I know you weren't director for a number of years, but is that your recollection, your understanding, that plasmapheresis was a long-standing part of the arrangements?
Yes, yes, I remember, because Tom Cleghorn, who was the director at the time, was a pioneer in plasmapheresis, and he started with manual. I remember seeing manual plasmapheresis when you had to collect a pint of blood and then take it to the blood components and separate the plasma and return the red cells to the donor.
And if we go to NHBT 00866659, this is the draft of a letter to The Economist from you and 2 of your colleagues, October 1987. I just want to pick up what's set out in the second paragraph. Plasmapheresis is carried out at most of the 14 regional transfusion centres in England and Wales, and plasmapheresis programmes are rapidly expanding. At the North London Blood Transfusion Centre, Edgware, the first unpaid volunteers began donating by plasmapheresis in 1967. The number of regular attenders now exceeds 2,500, and over 80% of these donors attend for donation once a fortnight. So is it right to understand that your centre's experience was that plasmapheresis was a very good way of, provided you had the necessary facilities, which required funding, a very good way of increasing the amount of plasma that you could obtain and therefore supply?
Yes, the best way.
And you told us in your statement that there were 3, you described state-of-the-art apheresis clinics as part of the centre's operations. Is that's right?
Yes, we had 3. And they still exist. The Western Donor Centre, Luton, and, oh God, it's gone out of my mind. We had 3 plasmapheresis centres at North London.
And then...
And Edgware, of course.
And then, if we just go back to your statement, page 116. The paragraphs 467 through to 472 of your statement set out your perception of the advantages and benefits of plasmapheresis. If we go to the next page, Seamus, in paragraph 472, you say, I therefore agree that plasmapheresis is a crucial technique to increase plasma yields and reduce wastage of red cells. And in my view of this has not changed. Self-sufficiency in plasma products is not achievable on the basis of recovered plasma without a considerable wastage of red cells. Such wastage would be immoral and unacceptable. Now, the North London Centre, as you've described, was obviously adequately funded or reasonably well funded to undertake plasmapheresis, perhaps because Dr. Cleghorn had been a pioneer in this field. Was it your understanding that other regional transfusion centres were not in such a good position, at least at the beginning of the 1980s?
Yes, that's correct.
And do you recall any discussions or any frustrations being expressed to you or concerns about the inability of other centres to do the kind of work that you were able to undertake?
Yes, I remember at regional transfusion directors' meetings, frustration of some of our colleagues.
More broadly, in relation to self-sufficiency, can we look at a letter you wrote to Dr. Gunson in 1990, NHBT 0015646. Um, 31st of May 1990. And you say, I'm writing on behalf of the Eastern Division of Consultants in Blood Transfusion. So this would effectively be you, Tooting, Brentwood and Cambridge. Is that right?
Yes.
Members of the division expressed their dissatisfaction about the lack of interest of the Department of Health in self-sufficiency. It was stated that it is not enough to say that ministers are committed to self-sufficiency if this is not backed by actions and financial support. We firmly believe the time has come to reassess the situation regarding self-sufficiency. And then you go on to set out a number of other concerns. You say there are very good ethical and financial reasons for the encouragement of self-sufficiency. And then there are specific concerns about the position relating to BPL, which I'm not going to trouble you with. More, on the broader issue of what you say there is a lack of interest in the Department of Health and self-sufficiency, that was your perception in 1990. To what extent, if at all, was that your perception, or the perception to your knowledge of your colleagues earlier in the decade?
I think it was always my perception.
And if we then, sorry to jump around, but if we go back to your witness statement, page 105, you say at paragraphs 420 and 421, with very few exceptions, the UK blood services have always been self-sufficient in labile blood components, i.e. red cells, FFP, cryoprecipitant platelets. All I can say is that my perception was that the Department of Health decided not to appropriately fund and subsidise self-sufficiency in fractionated blood products. And then if we go over to page 107, please. No, sorry, page 106 next. 425, you say, with the exception of when the Minister of Health was Dr. David Owen, I do not believe that the Department of Health took a genuine interest in self-sufficiency in plasma derivatives from voluntary donors. And then you refer to an issue relating to prices set for BPL and lack of incentive to collect plasma. And then if we go to the next page, please, paragraph 432, you say this, there were two issues with regard to achieving self-sufficiency in fractionated plasma products. A, the funding was not available. B, BPL did not have capacity or technology to produce everything that was needed to achieve national self-sufficiency. And then 433, if every centre had been funded like NLBTC, we would have been flooded in plasma with no problem in achieving self-sufficiency. And then top of the next page, you say, my view of historical events has not changed. And then if we can go to the bottom of this page, you say at paragraph 437, as I've stated, the possibility of collecting sufficient plasma from safe blood donors was always there given the willing donor population in the UK. Top of the next page, but what was needed was the political will and funding from the government and the Department of Health to utilise the willing donor population to donate regularly by plasmapheresis. Even if we'd collected all the required plasma for self-sufficiency in blood products, BPL did not have the capacity or state-of-the-art equipment to fractionate it all, nor the sophisticated equipment to produce the high-purity products available in the commercial market. Does that continue to be your view of the position in relation to the non-achievement of self-sufficiency in blood products in the 80s in the UK?
Yes, it continues to be my view.
And then can I just ask you about the production of cryoprecipitate? That was presumably a blood component produced at the North London Centre?
Yes, of course.
To what extent, if haemophilia centre directors or the Department of Health had come to you in 1983, 1984 and asked you to increase the production of cryoprecipitate as an interim measure in response to the AIDS crisis. To what extent would you have been able to do so?
Oh, to a large extent, but we were not asked to do it. But we had the capability to do it.
And was there ever any discussion with you by, first of all, the Department of Health about that possibility?
No, never.
And what about the haemophilia centre directors or centres that you supplied?
As far as I can recall, I cannot remember any haemophilia director asking me for cryoprecipitate, for more cryoprecipitate than the usual. We produced a lot of cryoprecipitate, but that was usually for maternal hemorrhages and massive transfusion.
So I'm going to move to another topic now. So perhaps we could take the break now, and then I can start with the next topic after the break.
Yes, well, we'll take a break until 20 to 4 in that case, 20 to 4.